Well, good afternoon, everyone. Thank you for attending the Transplant Institute lecture series. My name is Marwan Albuzoud, Director of the Transplant Institute, and it's a pleasure to have today Jennifer Milton with us. She's been attending for it before, and we work together. And it's a pleasure to have her speak to our group. The focus of our presentation today is the nursing perspectives in transplantation and solid organs. The transplant coordination and transplant dimension of our transplant enterprise is very critical to the effectiveness and the success of a transplant center. We quite often oversee or don't pay enough attention to the importance of the role of transplant coordinators' role or nursing roles to the effectiveness of a transplant center. And in the current environment, regulatory pressures, outcomes, transparency of processes, complexities are adding a lot to our workforce. And now it's good to bring up top of mind and awareness, understanding of the framework, and perhaps set the stage for what's next to come. Jennifer Milton is a very unique individual. She's combined a unique set of talents, starting off as a nurse, becoming a Ronco recovery coordinator, a transplant nurse manager, and going on to get a master's degree and then becoming a transplant administrator. She's like a Swiss knife in the transplant space where she can have an opinion and good thoughts on everything. She started off at the American University of South Carolina and moved on to Texas, where she became the executive director of the transplant center at UT San Antonio. And she also is a clinical assistant professor with the school there and has worn many hats. One of them, she co-developed a tissue bank through the University of Texas with the clinical leadership there that she directed up until a year ago. And it was sold by the organization to a private enterprise. She was the Region 10 counselor for the local region in Texas. She also worked with UNOS quite heavily. She's now the chair of the Policy Oversight Committee, and hopefully maybe she will get lighter on policies from UNOS. And she's involved also with Donate Life America and also involved heavily in the early stages with the AST Communities of Practice for Transplant Administration, where she's a council member as well. So with that background, rich background and portfolio, and having a nursing background as well, we welcome Jennifer to speak on the nursing perspective in solid organ transplantation. Jennifer, thank you.
Here we go. Well, I thought I would, after that long introduction, tell you a little bit more about myself. I'm a really big hit at Career Day. How many of you get to speak at Career Days? Right. Well, I take Career Days to this whole other level, right? I bring in a cooler, human organ for transplant, put on the white lab coat, usually have this room full of 5th graders or 3rd graders and set the cooler down right in front of all of them. And this one was going particularly well until they asked my daughter, Cohen, hey, do you want to come up and introduce your mom? So Cohen trots up and she says, well, this is my mom, Jennifer. She's a nurse. Well, she's a fake nurse. She saves people's lives through transplant, and on Friday night, she serves snow cones at the football games. So I launched into my great talk on organ donation and transplant. I moved those little kids to tears. The teachers were just enjoying it, and at the end, 60 little hands shot up, and what do you think they asked me? Do you have pina colada snow cones? Can you get 3 flavor snow cones? How much do you sell just the ice of snow cones? So I'm giving you a nursing perspectives lecture. I'm not necessarily the expert. And 2, my children think I'm a fake nurse. I started transplant nursing 24 years ago. I graduated from nursing school in upstate New York, went immediately to work in the ICU. It's really that good of a story. So went to work in an ICU, had never learned in nursing school a single thing about organ donation or transplantation. As soon as I got my own caseload, I was about 6 months out of nursing school, and I took care of a gentleman who had died unexpectedly of an AVM, and his family chose for him to be an organ donor. And I realized that was the coolest thing I had ever seen in nursing, and I stalked them until they gave me a job, because normally they'd only hire you if you had 5 years of nursing experience. I went to work for SCOPA, South Carolina Organ Procurement Agency, now called LifePoint. And they send you down to their busy transplant center at MUSC for 3 months to train you how to be a transplant donation coordinator. My first night off of orientation, I was in the Richland Memorial Pediatric ICU. This young girl had been in the back of a daycare van going over a hill, and they had all the children in seatbelts except for Michelle. And they were stopped because of some work on the road, and a teenager came over the hill and rear-ended them. And Michelle flew to the front window, hit her head, and she was a closed head injury. And on that day, I went and did the referral, met her family. The mother had so many medications, she was in essence a zombie. And she sort of chastised me for being there. I left the hospital, went and wrote my letter of resignation. I got a call to come back to the hospital. Michelle's father wanted to talk to me. And when I got there, he said, "We want to donate." And the mom was still kind of a zombie. We've thought about it. We really want to donate. And if any of you worked for organ donation programs in your history, one of the questions that you have to ask when you consent someone to donate is, do you have any special wishes? It's the oddest question. You're asking all this medical history, all this social history, and then you get this question, do you have any special wishes? And when I asked Michelle's father, do you have any special wishes? What does that mean? And you sort of go on to describe, well, maybe you know somebody on the waiting list, or maybe you have a special timing of the burial, or you try to explain it. And he thought, and he said, well, ever since she could speak, she's asked me to get her ears pierced, and I've always told her she had to be 13, but on Sunday she turned 6. And I took her to get her ears pierced, and my special wish is don't take out her earrings. So I'm from South Carolina, and this is how they teach women in South Carolina to cry. Right? You don't cry, you're a lady. I started crying so hard, if there was a hole in the top of my body, liquid was coming out of it. A snot, and my ears were draining, and mascara was pouring down my face, and I was heaving. This man had lost his only daughter right after her 6th birthday, and I was a puddle. And he slid across this chair, and he grabbed me by the shoulders, and he said, go do your job. Because when I leave the hospital today, I'm leaving without Michelle. All I'm gonna have is her memories, all the joy that she brought us in her life. Go give that to other families. That was 24 years ago. I write him every Christmas, and I tell him that she saved my career, and I'm on the board of Donate Life America, and I'm the chair of the Policy Oversight Committee, and at every opportunity I get, I try to share Michelle's story, because donation and the act of donation is often a bigger gift to the donor family than it is to the recipients that we serve. And it's an honor to work in transplantation and honor those gifts. And I'm gonna talk a little bit about how Michelle's story really inspired a big change in nursing when I got to Texas. So that's kind of always my proof that I've been in transplant for 24 years, because that is my Franklin Daily Planner from back in the day. But when I became a nurse manager, I wore a lot of hats, as Marwan said, and when I became a nurse manager, you had I ran the nursing floor in the nursing ICU, and I interviewed tremendous number of nurses, a lot of them coming out of school. So you always ask the nurses this question, why did you become a nurse? What is it that drew you to nursing? So what do you think these are my answers over the years. All of the answers came back to the connection of passion, and that nursing is a fulfilling job. I want to help other people. Over the years, people began to talk about security in the profession and the ability to know that when they graduated from school, they were going to have a job. And always we heard about opportunity from these nurses that we were interviewing. Maybe it was opportunity to further school and go on become providers themselves in nurse and anesthesia or in a nurse practitioner realm. Or it was just opportunity to grow into a PCC or a charge nurse, a nurse manager, and then a nursing leader. So I think those were just really the themes over all of these years of management I heard over and over and over from new nurses, seasoned nurses, and on and on. I did also hear, well, my mom did nursing, my aunt did nursing, but really still it came back to that fulfillment and that passion. So if we talk a little bit about transplant nursing, how many of you are in transplant nursing? So if I go to a group of transplant nurses with that backdrop and I say, well, what have you been up to lately? Right? This is what I tend to hear about in transplant nursing. I hear about all the regulations, the big push, constant need to be compliant, and all of the audits are happening in a program. I hear constantly from my own nurses and others across the country about how much transplant nurses work in the world of finance and dealing with patient insurance issues. Of course, a world of statistics and what the SRTR is measuring and tracking and how we're tracking patient satisfaction, tracking everything. And more what we hear in transplant nursing is the pressure to do everything, hurry up, get them here faster, move quicker, do more. So I will say now, so any of the transplant nurses that raise their hands, raise your hand again if you feel like those are some of the domains you predominantly work in. Yeah, right? So now I will kind of another disclaimer back to my snow cone disclaimer. These are the areas I always speak in. This is my world, transplant administration. I love this stuff. I love transplant regulations. I love transplant statistics. Financial is just my thing, and I enjoy running both the insurance side and maximizing my reimbursement on every case and looking at my coding. Those are things I love. That's probably why I'm a transplant administrator and thankful for the patients that I'm still not providing care to the patients. So I'll talk a little bit about each one of those. I could speak on each one of these individual topics in 3-day workshops, if you would ever let me. So I'll try to just hit some highlights in each of those arenas, and then we're gonna kind of circle back around and talk about how to make life a little bit better for the transplant nurses in each of these domains. So for transplant regulations, of course 2008 is when I feel our whole field of transplant changed. That's when Medicare released the conditions of participation. They actually released them in 2007, but they came effective in 2008. I have this nice little chart I show sometimes when I give talks that shows these big eras in transplantation, and I think everyone would say that cyclosporin was an era. You know, we finally resolved the first step of the immune system and put organs in people, and in general they worked when we discovered cyclosporin. And then that success heralded NODA, and NODA defined brain death and set forth the structure of transplantation, and that really changed transplantation. And I would say the next big era that happened in transplantation was after the release of the conditions of participation. And what I think that they did, really the conditions of participation came about in large part because of an investigative news series that happened in California of what was happening to transplant centers and the feeling of the government that UNOS, our peer organization, was not policing our own. So what we ended up with was a large set of micro regulations. There really isn't another set of regulations, even if you look at Joint Commission's Medicare hospital conditions of participation that are as prescriptive as the transplant center conditions of participation. It really pushed us to standardize care and to standardize our outcomes. It told us when we needed to provide informed consent, what the elements of that informed consent needed to be, how you were going to do, and who needed to give multidisciplinary care in the hospital. That was really a set of micro regulations. But just to kind of throw a lot of confusion in there, they left a bit of it open to interpretation. So there are still things today, it's kind of the tail wagging the dog phenomenon, that have almost become folklorish in transplant. I gave a couple of little analogies there, I visit a lot of transplant centers in a year, and I still get asked this question: can the nurse caring for a living donor also provide care to the recipient? So if you say yes, they can, raise your hand. And if you say no, they cannot, raise your hand. Right? So they can. There is no regulation at all that states nursing, social work, physicians, dietitians need to be separate on two separate teams. There is a federal regulation that says you must have one team member, one, who is independent. And what is that role called?
Donor advocate.
Independent living donor advocate. Right. So that's an example of where kind of policy and regulation and practice and good patient care all became sort of muddled together, and most centers in the country feel strongly that those need to be two separate nurses caring for those patients, or two separate staff members caring for that patients. It has implications because as you're looking in your own kidney program to maybe restructure so you handle waitlist management slightly differently, it's being sure that you know that those nurses can handle both patients' assignments or can do it a little bit differently is an important thing. Another area that I think became a little bit of a legend, but not necessarily buried in fact, is when you guys start out a transplant evaluation, you have one of those long acknowledgement forms, right? So in the first education class you do you have the patient sign that?
Yeah, the check.
Kind of along the way of an eval. So most transplant centers adopted this sort of 9 or 10 page, size 10 font acknowledgement form. And if you've had a career in nursing, one of the things that's drilled into you is readiness to learn and teaching things at the right time. And so for a lot of transplant centers, they adopted this extensive education class. And early in a transplant patient's evaluation, and you kind of have this output of a transplant patient who doesn't remember most of the class because it was such an overwhelming day already. So that's another area where I think just confusion existed around what the federal regulation was, and the actual regulation made it a little bit worse because we just went with a presumption. Instead, you really can break up patient education, teach it in bite-sized chunks along a continuum of care when they need to know it, some of it at home, some of it at the hospital. It culminates with a documented educational kind of continuum and record with never having signed an acknowledgement form. That's perfectly regulatory accepted, but just hasn't been the norm in the country because of the confusion. So UNOS, of course, is another layer of regulation that transplant nursing deals with perpetually. And once again, another layer of confusion. Medicare releases its regulations about every 20 years. We have 20 years to figure it out. We're 9 years in and we still really haven't for the 2008. UNOS issues policy. How many of you are on the UNOS policy alert? Yeah, I apologize because I'm the chair of the Policy Oversight Committee. We are issuing policy memorandums almost weekly. Even though the board of directors only meets twice a year, policies are in a constant state. We'll release a policy, it will be voted on nationally, but it gets reminded to you when it's about to be effective. So by the time it's effective, you've sort of forgotten that a year ago it was released. I'll give you one example is pediatric transplant programs are going to have a standalone approval, a component. So if you plan in your lung program, heart program, liver program to occasionally do a kid that's 17 here, that's a pediatric program. And you're going to have to apply to be an approved component. Kind of like live liver donor programs had to apply for a component. Well, that passed UNOS committees at the end of 2015, but they haven't developed the application or the credentialing process yet. So sometime in 2018, we're going to have to be compliant. So you just add that to a bevy of policies coming out every week, and every week they're going to be due and need to be hardwired at a different period of time. It's extremely frustrating environment to work in. Add to that many of the UNOS regulations overlap the Medicare regulations, yet they're slightly different. So how many times, I would say in the last 5 years, have you changed your ABO process in the OR more than 5 times? More than 20 times? It's probably more than 20 times. I can't even get a policy through my hospital or forms committee for 6 months. So I've pulled my ABO policy 3 times because of either UNOS regulations or a new interpretation from Medicare just in this last year. And it takes a while to train and learn new regulations right before you have to make another tweak. So I think the regulatory environment that I love has been a significant dissatisfier for my transplant nursing staff. So I'll shift over and talk about compliance. They're slightly different. Do you audit your records when you place a patient on the waiting list? And do you audit your records after transplant? And when you remove a patient from the waiting list, right? So most of the country shifted to that. We used to have kind of a reactive quality approach. Something would happen and we'd sort of react and look to do a corrective action plan. When the Medicare conditions of participation were released, we switched to really a proactive approach. So we started doing 100% audits, and then we tried to shift those so they were more in real time and we could catch mistakes as they were happening. But I would argue that re-engineering your quality program at some point and looking to do it may be a good resource or use of your time, because I think what's happened with our audits is they're protective. So when you do a 100% audit to see if you did 2 ABOs, are you making your patient's life better? Or are you protecting your program from a ding at a UNOS audit? I think that you have to infuse in your quality program an equal smattering. There is no statistician in the country that will tell you 100% audits is statistically relevant to some greater degree than an appropriate sampling size. So if you can ever consider looking at how you're doing quality and looking at the role of chart audits and really making sure you have an equal number of metrics that are focused on the quality of care and the patient experience as just being compliant with a set of regulations. Because it's a lot of resources and man hours to do constant data abstraction. The other thing I kind of, and I'll talk about it with some solutions in a minute, but I felt like at some point we were just at my transplant center beating my nurses up. We were constantly letting them know when they hadn't documented this, or this was a problem, or this was a problem. We weren't doing it to be punitive. We were really doing it to be protective and protect their center, but really ending up with a group of very frustrated nurses. And I would say, since the Medicare, another area of compliance is almost every transplant center in the country has a transplant quality nurse. For those of you that don't know, you were a real pioneer in that. You had a transplant quality and regulatory compliance member before it was cool to have one. So finance, again, my favorite subject, and hopefully it doesn't make any of you queasy here right after lunch. Insurance reform was well on its way before Medicare issued these conditions of participation. But the insurance world in which we're practicing transplantation is one of the absolute most frustrating. We have become centers of excellence because of how expensive they are. The transplants are. If you just Google top 10 most expensive surgeries in the United States, 7 of 10 are transplants. are our transplants. So of course insurance companies want to mitigate their own risks. Of course they want to have case managers and prior authorizations. So we're working in transplant nursing and trying to get these patients along in their care and just explain the complexities and help them address their fears and talk about adjustments with a transplant. But many of our nurses are on the phone doing these things: getting prior authorizations, for procedures, for pre-hospitalizations, for medications, trying to struggle through all of the ICD-10 coding, maximizing the ICD-10 coding with medical complications, without medical complications. If only the surgeon would have written acute renal failure instead of chronic renal failure, we would have had $25,000 more. Getting the right CPT codes, the insurance companies wanting to speak to a nurse to get all those things done. Battling as a transplant nurse with, is it cost reportable, doing your own time studies. Many pharmacy restrictions on our patients, and you have a patient, you feel like you've just, that's it, we've saved your life, and they go to the pharmacy to get their first fill of prescriptions, and every single one has a $45 copayment, and they're still stuck with a $1,000 bill, and they felt like you had told them that they were well insured. Or you're battling brand versus generic, and those again are things that I think are detracting you constantly away from delivery of care, educating your patient, working with your patient. The ACAs have been amazing for our transplant program, absolutely amazing. I feel like we can work together and save a patient's life with about 30 days leeway now. And if you worked before that, before you really had that luxury of something that didn't have a pre-existing condition, you had so many patients who never made it to the waiting list. But what's happened to us is we transplant about 100 ACA plans a year. And if you know after you transplant them, you have to monitor if they made the payment on their plan, because those plans terminate in 30 days. So we used to deal with that with COBRA and a couple of other TANF plans, but now every 30 days post-transplant, I've got staff members that have to call to make sure that the check cleared. And the reason that you have to do that is you're given a 90-day grace period. So it happens to you one time that you transplant a patient, they were too sick, they didn't make their first payment, they didn't make their second payment, and the next time you get a notice is they lost their insurance back to before the transplant, right? So now I'm going to talk about statistics and SRTR in a minute, but that level of compliance, if you don't have a cadre of social workers and a cadre of financial coordinators, and I have not met a transplant program in the country that has a dedicated post-transplant financial coordinator, that's all they do. Guess who that falls on? That falls on transplant nursing. You kind of become the jack of all trades, coordinating, particularly through those post-transplant nightmares patients might encounter. And carve-outs and global periods, I can't stand those, but that's when the patient hits that magical day of 90 and they now have to go to Quest and LabCorp. They can't get a bronch at your facility, they can't get imaging at your facility, and they can't get labs at your facility because now they fall to the general medical contract. Well, if you're seeing 47 patients in clinic that day and your patient's having a complication, who's supposed to remember that? Well, you figure it out when your patient calls in 2 weeks and said they just got a $3,000 bill and they're not coming back to your transplant center again. They can't believe that you did that to them. So again, kind of falls to nursing, particularly if you don't have a good database that's triggering those things for you. This is getting a little depressing. Sorry about that. Statistics, I'm not going to belabor too much, but it's the world we live in, and that's the SRTR. So you are what you enter. The SRTR is not just about who you're transplanting, it's about how you're documenting in your medical records and how that documentation is later used to help you or used against you. Some of you were here and you heard Marwan say in partisan management, we came through and did an in-depth scouring of your data, but entering data accurately and thoroughly has also been something that's fallen on the nurse coordinators. And I know in your HEART program, and it's also happened in some of your other programs, if your statistics begin to waver, and any of those insurance companies send you the "Dear John, I'm breaking up with you" letter, then suddenly you've got a volume problem, you're grandfathering patients in, you're dealing with referrals that can't see you anymore, just another really frustrating factor to your job at times. And I'll last talk about one of the areas that my transplant nurses, if they could get in my door, could strangle me at times. And this is all those metrics. The end result of all those metrics we're reporting in quality is this need to go faster. We're being monitored for our next available appointment in all of our clinics. We're being monitored for our referral to listing. We want it faster. We want to see patients faster, and we want them on the waiting list more quickly. But we want more tests, and we need to document it, and we need to do it in a really compliant fashion. A big push to never have status 7s on your waiting list. Get them down, get them down, get them down. Does any of this sound familiar to you guys? Getting asked to do those types of things. Everyone wants as short a length of stay, right? We want to do a heart transplant and discharge them that night, don't we? Right? Why aren't you discharging them right away? And we want no readmissions, but get them out of the hospital as soon as possible. And of course, more living donors. So there's this kind of constant pressure that the transplant center is a business, and we need to work efficiently and effectively and keep it as profitable as we can so we can ultimately save as many patients as we can, right? So all of you agree those are realms of transplant nursing you're now working in? Yep, and transplantation. And not one drop of it was compassion or fulfillment or opportunity or, right, security. So none of it really related back to why so many people went into nursing. So I'm going to talk about two solutions, I guess I would say, that we implemented. And some of you might think this stuff is a little frou-frou when I talk a little bit about the role of passion in a transplant center. But I think I'm going to make a business case for passion in the transplant center. But I think two areas I really wanted to focus solutions, I guess I would say. When you take nurses who are driven by passion, fulfillment, security, and a desire for opportunity, and you immerse them in regulations, compliance, finance, and getting faster and faster and faster, you can end up with a cadre of nurses who are burnout and disillusioned. And that's a little scary because people used to say you would get the transplant bug. So they used to say you would hire these nurses like me. Here I am 24 years later, still in nursing. I have a group of nurses that have been with me for 15 years. They don't want to go into leadership. They love transplant nursing. They've been there 15 years and plus. All over the country, almost every transplant center I go to, those nurses are there. Those staff members are there, not just nurses, the ones that love this field. Doesn't mean they're not burned out as well. So I think two solutions I really like to talk about are the role of leadership and the need for more leadership in many cases, and then sort of a case for passion. So I would say for leadership, one of the big shortcomings we have as transplant centers is that we forget to scale leadership as we grow and as the complexity of our program grows. So in my own transplant center, because our liver program, we began to manage a group of patients that were too soon for transplant. It's a terrible name, but we call it the Orbit program. And we didn't want to lose them to our competition, but they were definitely too soon for transplant. So I have a team that manages this Orbit group of patients. We opened the Texas Liver Tumor Center because we had so many patients with liver tumor. They were being referred a bit too late when transplant was really their only viable option. We opened a live liver donor program. We opened a pediatric transplant program. All of this was happening between 2010 and 2012. And I had this one poor liver manager doing all of that. She went from one set of regulations to no to 5. She went from one set of doctors to 5. And on, different types of finance, different types. So now you look at where I'm at today in my liver program, and each one of those components have a manager, and in some cases I have clinical directors. So I think if you have an individual program and that program is branching out and diversifying, there's a case to be made to add a layer of leadership as you're staffing it, so that the nurses don't have to spend their day interpreting finances and compliance and regulations and dealing with metrics. The nurses can have that, not nurses, the staff can have that chewed up, put into a process, made into a system, and then give that a try with you that you give input to doing. But I think when we diversify and grow, all of the nurses become sort of in a management role when there isn't a service line or a subject matter manager in that role. I think the other thing we've done that really has been successful in our transplant program, and I would challenge you with your leadership team, is as we grew more management, which I think was pivotal to our programs being able to sustain this growth and massive changes in the program, we integrated and cross-trained deeply. We decided to put one inpatient team in place, and that is 3 case managers and 1 educator who does group education classes. It doesn't matter if you had a lung or a pediatric liver or a pediatric kidney or a pancreas transplant, you have the same educator and the same group of case managers. We quit floating in our pre-team to educate and floating in our post-transplant team to do discharge coordination. That has created this incredibly talented group of discharge and education specialists. And during times of staffing crisis or a big uptick in my volume on pre or post-transplant, I have a balance of what that group doesn't have to float in and cover because I have a big enough group and inpatient. I also mandate cross-training of my leaders. So we talked about chart audits. My lung manager has to do chart audits from the other programs. That's helped us standardize our records. We've standardized how we do some training, and I'm going to talk about orientation in a minute. And we've made a commitment that developing our leaders never ends. I tell staff all the time, just because somebody's got a title of a manager doesn't mean they have the wisdom of a manager. It's a title that people have earned, but they're constantly learning, and leadership has to be good at HR, good at operations, and good in all those other domains I just talked about. You can never stop grooming and training your leadership. And some other, I mentioned earlier, the real goal, I think, of expansions of leadership, cross-training and integration of leadership, is to take the burden off of the staff and the team and help them put systems in, and they can then work on evaluating those. We also had a constant complaint that when we didn't have that many managers and our medical and surgical leaders would make a decision to make a change, the coordinators were finding out about it too late. They didn't understand the rationale, change was happening, they never felt like they were in the loop. So we've standardized very simple ways to communicate change. There's a very simple tool you can buy called a screener. And what a screener does is it films whatever's on your desktop and your voice. So I can open up a policy and say, hey everybody, I'm reviewing our new live liver donor policy. We had to change it because UNOS told us to do this and we discovered we weren't doing it. You don't have to review the whole policy, but these are 5 things you really want to know, and this is the one thing the liver manager might struggle with, so really look out for her in that area. I can hit send, and 200 staff members get it at once, and a group of 20 doctors get it at once. I know the change has been communicated. It might not be the way later in a liver quality meeting, we might go over it more in depth, get some feedback, but I know that my team knows when change is happening and has an opportunity to question that change before it goes into place. We standardize our orientation and annual competencies. We had a huge problem of leaning on the nurses to do too much, training the trainers. We discovered that we did not want our seasoned nurses being the one to train our data policy or how we did education inpatient, because it was really like the old game when you were a kid. One person heard it this way, and then they went and the telephone game, they went and told the person next to them, and they told the person next to them, and then you really couldn't quality control how the newest nurse was oriented because you were 3 layers deep into who was training the trainer. So we, again, did a lot of videos. We onboard all the nurses in a standardized fashion. And for their annual competencies, we shifted to a skills fair, just like when you were a bedside nurse. And our schedulers, medical assistants, licensed vocational nurses, file clerks have to go through station-appropriate training as well. For financial, we felt my heart broke for our transplant nurses who were constantly in the position of explaining to patients their financial benefits. So what we did is we had our financial team create a really robust tool that explained co-payments, deductibles, co-insurance, exactly what the patient was going to pay. And we discovered that if the nurse could put their hands on that education to the patient and read it, then the nurse was really going to understand and be on the exact same page, which is where some of the frustration lied. So we tried to put the right tools in our nurse and staff hands so they weren't having to function as little financial coordinators at all times. And then lastly, I think we have to be really careful with transplant nurses. They all think that they're superheroes. And if you really sit down and somebody needed to do this, somebody needed to go back and do all the 340B paperwork, or somebody really needed to go work with a home health company to do it, what we found is it was our nurses who were volunteering to do anything. They weren't being assigned, they just knew someone had to do it, and all of a sudden their own job descriptions were so inflated with project work and extraneous work. So now we have a rule at my transplant center that you are not allowed to take on another duty that's going to last longer than 1 week unless you have approval from your supervisor. And that has reduced the burden of additional work for the transplant nurses tremendously because nobody really just knew all the additional work they were taking on. I would think another role for leadership, and I hope I don't see a lot of nodding of heads, but really intense management and training and onboarding of the secretarial, administrative, scheduling staff so that they were high performing, highly engaged, and very passionate, because they're the nurse's voice to the patients. They're the nurse's ability to get to the patients and not do a lot of that work. And I know that my nurses were unrelentingly frustrated that they felt that they were being held and audited constantly and held to this very high standard, but the administrative pool was not being held to as high a standard. So we've implemented a lot of things so that group works closer together. They set metrics together, they audit each other now, and I think now that we've got a passionate, engaged group of admin support, our nursing satisfaction has really increased as well. I think another thing I didn't really talk about, but many transplant nurses would say, just managing databases and IT is a perpetual source of frustration. So we do have a dedicated transplant IT team, and they have once a month, they're required to walk rooms, and they go to the transplant nurses, and they make them open Excel. And then they say, show me in the recent column all the things that you were working on in Excel. And what you find is that the nurses are creating their own spreadsheets of patients, which means the database doesn't work for them. So IT's job is to go scour Excel, scour PowerPoint, and then go back and try to make the database produce that report so the nurse doesn't have to keep a separate list, which isn't good for the nurses and isn't safe for patients. The other thing we did is we looked for constant feedback from our providers and from our patients, and we looked to reward our nurses and our allied staff constantly in real time with real patients' words, because we realized we had to counterbalance all the negative coming out of the chart audits with sincere, timely positives. And that has been a really incredible boost. And I'll show you a little bit how we did it. So I said I'm going to talk about a little bit of the frou-frou stuff, and this is a little bit on our real drive to make it a more passion-oriented transplant program. So again, going back to those interview questions and what motivated staff, and we did this 100% to improve our retention and our patient satisfaction scores and our provider satisfaction. We improved nursing satisfaction. So there's this great book called John Carter's called The Heart of Change. And it basically says if you want to change somebody's behavior, they need to feel the change. Right? So if you wanted to, they gave a story in the book of in the Windex factory, they hung pictures all over the factory of people using Windex, fighter pilots cleaning their windows, and a little NICU incubators, the glass being cleaned with Windex. And it totally changed the employees' perceptions of what they were doing on the factory line. So we started thinking at our transplant center, how could we do that? And I told the story, I was watching one of those infomercials late at night. I was dealing with a fulminant liver failure with no insurance late at night. And an infomercial was playing, and they interviewed a guy who'd done his fellowship at St. Jude's. And he must have been 80 years old, and he was telling why he gave money to St. Jude's every year. And he was at the end of his career, a retired physician, and he said when he was a resident, those kids got to ring a bell when they went into remission. And he said you'd look down the hallway, and as far as you could see, all the families were poking their heads out. And you could see their face just wanting to be the kid ringing the bell. And as he's telling the story, this is an 80-year-old physician, he's crying about the way that bell made him feel every time a kid rang it. And he talked about all the residents and how they felt, all the providers, all the nurses, everyone came out, and the families and the hope it provided. So guess what I did the next day? The next day, I walked into Dr. Ploth's office. He was the chairman of nephrology, and he had bells all over his office. And I'm like, well, what are those bells? And he said, well, he's a sailor. He said, don't you know that the bell is the soul of a ship? And he said, so every time a bell's a big deal, every time something momentous happens, they would ring the bell. And you know, maybe a crewman had a baby, or his wife had a baby, or they had a big, they did some great big job, or you know, they really traversed a really wild storm. He said they'd all ring the bell. So I said, I want a bell, I want a bell. So we hung a bell at MUSC, and we tell pre-transplant patients, the first walk after a transplant is to ring the bell for the soul of your donor. We videotape it from their walk to ringing the bell, and now all of the attendings do it on rounds, and there isn't a dry eye in the house, and guess what every other transplant patient on that floor is doing? Looking down the hall, because that's where our pre-livers are and our pre-lungs are, right? The morale on my floor, the morale with the attendings, the fellows, the nurses, you don't miss a bell being rung. Right? It totally shifted, and he donated this bell to me. It costs nothing. We take a picture, we tell the patient it's for the soul of their donor to ring it and go forward and live their life in honor of that donor. And if you just Google MUSC bell, you'll know there's 20 of them in California now, and a transplant bell. But just a small way to celebrate the miracle of what you guys do every day. Tiny way to do it. I moved to Texas and had bigger problems when I got there. So I told you, I believe we're stewards of the gift, and I think I've always carried Michelle's story with me. So we totally revamped our orientation. Every employee at my transplant center starts at 10 a.m. on their first day in the coffee shop with a transplant recipient, buying them a cup of coffee. And all that transplant recipient says is, I just need you to know how important you are and how much your job matters. And all that recipient's job is to tell their own personal story. I want that to be your first impression if you're being hired to be a receptionist at the clinic or a transplant nurse coordinator for my wait list on kidney. Any job in the transplant center, that's how you begin. We have Transplant University now. Once every 6 weeks, we have an entire day of training so that there's no train the trainer. You hear it right from the horse's mouth, whether it's data, policy, patient satisfaction, et cetera. You cannot pass your probationary period unless you personally have observed a transplant and attended our OPO's best practices class. You are required before you finish orientation to go down and help a recipient write a letter to their donor family. We have other tours that they go on. We do something similar to our residents. We do a lot of other kind of bells and whistles, and I'll show you Faces of Transplant in a minute. I know that sounds a little frou-frou, but when I'm dealing with nurses that are facing burnout from regulations and statistics, I can tell you they come back to what happened on their first day, watching that transplant, going to watch and work with that family to write their donor letter because they saw their transplant, all has really changed and keeps the nurses focused on their mission. And anytime they hire a new nurse, and we don't just do this for nursing, we do it for all of staffing. We modified that, and new leaders in our hospital attend a version of Transplant U, and they observe a transplant. We also have a lot of events we do when a donor donates, we raise a flag. The entire transplant program comes, the donor family comes very often the day the donation is happening. We fold the flag American style, and then we travel it all over the hospital, and people touch it, and they're a part of the donor ceremony. And then we recruited these patient ambassadors. If any of you have gone on a Carnival cruise ship, and they took a family portrait, and they put it in one of those cardboard picture frames, any of you have those? You kind of never take it out of the cruise ship photo frame. Mm-hmm. So we made one of those for ourselves. If you open this card up, it says University Transplant Center Saved My Life. We tell every patient that if it weren't for the referring doctor sending them, they wouldn't be alive. We take a picture of the patient, University Transplant Center Saved My Life, and then we tell them to write, we'll give the patient 10 copies. They write a thank you card to their insurance case manager, the referring doctor, their school teacher, their brother, anyone who helped them along the journey. And I can tell you almost 100% of the time, the nurse coordinators get one. Just giving our patients a vehicle to say thank you in a meaningful way has been extremely powerful for us. We also kind of took this concept and ran with it, that a forever stamp is 47 cents, and what could we do with that picture? So we send, I said to the referring doctors, insurance companies, we also send a beautiful letter to the elected officials in our recipients community, always naming the nurse coordinator that helped them along that journey, and then inviting them to create a pulpit to sort of say thank you to the living donor or to the recipient, their place of work, their place of worship. Just a group of letters goes out with the patient's permission immediately, and we get a lot of those politicians writing our staff, thanking them. Thank you, we heard about the great work you did with Mr. Alvarado, and we're so grateful. And so we have this kind of perpetual thank yous happening in exchange for our 47-cent stamps. We hired a volunteer coordinator, and she now channels all of our volunteers. And these are the pictures that we take. We call them the faces of transplant. And if any of you follow on Facebook, like Humans of New York, we just stole their idea, right? So like it will be a picture of the patient, and then some little teeny story. Like one man will say, my wife finally got off dialysis after 7 years. She looks so good, I'm worried she's gonna leave me. You know, it just cute little glimpses into restoring patients back to their life. And anything that we can put in, it's just a little blurb. Again, connecting our nurses right back and the passion it instilled in all that we do. And we send this to the OR, to radiology, to the lab, to emergency services, all those departments for whom we are not popular people, right? Those guys don't like transplant. We drive them crazy, the blood bank, the lab. But now that they get faces of transplant, one email is all it cost me, and volunteers to go out. We had somebody come in and train our volunteers how to take these pictures and how to catch these little snippets. This program, Faces for Transplant, is totally free for us, but has really turned our staff around and connected them back to the mission and to being fulfilled. So I'll kind of wrap up here and say, I think instilling passion and investing in leadership when you're a program who's growing and changing and struggling with regulations and struggling with the statistics was where we were at in 2012. Our kidney program went from 450 patients on the wait list to 1,000 in this short period of time. We had way too many status 7s. We had this amazing group of patients. No one even knew where they were at. They were just a backlog, we call them. Our transplants doubled during that period of time, and it exposed, we had no infrastructure and a lot of really burnout staff. So we had high turnover. So we launched the Stewards of the Gift program. We implemented broader and more leadership. And I just recently told Optum when they did a Centers of Excellence visit, I think we're now the triple threat. We're growing substantially every year. Our patient survival from the SRTR and all of our programs is in the top of our region, and in some programs the best in the country. And the thing to most be proud of is that we're an NRC Picker Center. We have a dedicated transplant ICU, dedicated floor, and dedicated clinic. And we're top 5% in NRC Picker in the country, and the highest in the hospital the entire time since we've been with NRC Picker, since we started this program. Our physicians are happier, and I think it is because we have the right combination of leaders to support our staff in real time with organ-specific needs. And I think that we celebrate everything we do, and we realize that our patient stories, and we forgot the miracle in what we do for the work to get there. So I think it's been a special place for the people that are working there, and our turnover is less than 3%. And I think that I would tell you, if you talk to our transplant nurses, our staff, they would tell you, tell me what you like about working there, and they will say, it's a passionate center. All of our management roles, we have opportunity for growth. So they have opportunity. It's a secure place to work because we're growing. There's always jobs opening. And then we have the right amount of leadership to sort of digest and make the staff work, let them work, because we can put the systems in place. So thank you very much.
Thank you, Jennifer. Open for questions. Nobody can go to Texas and work there. We need you here.
A good place to start is somebody call and set a meeting with your volunteer services and get me on the phone with them, and I'll tell them how to get started with a couple of the things. They're not too hard, and they usually don't cost the transplant center a lot. Yeah. And I know we're talking about looking at some leadership advice.
Yeah, thank you. A question for you. You mentioned that you have low turnover. In the past, it used to be that quite a few of our coordinators came from ICUs or transplant floors or whatever in the hospital, but generally transplant related or ICU. With your growth now, how do you do your recruitment for coordinators? And then, of course, you plug them in that program.
Did you guys hear that question? With the growth that we've been having, how are we recruiting coordinators? I talked about Transplant University, Transplant U, and Transplant U includes the nurses on the floor in the ICU. We'll also invite some others and do an abbreviated version. But we treat our nurses on the floor and our nurses in the ICU as if one day they're going to want to be transplant coordinators. So kind of back to that, wanting people to feel that they can progress in the field and they have opportunity in the field without leaving the field. So I think we try to really showcase transplant coordination as a lot of people leave bedside nursing and they want a Monday through Friday kind of job. And so we really try to bring them in early. Maybe they're just brand new nurses, but 3 years later, they tend to be the people applying for my jobs. Transplant U allows bedside nursing to get really integrated. And I didn't talk about it, but we do a birthday girl and birthday boy program too on the anniversary of a transplant. A patient gets a big sash near the anniversary, their next ambulatory visit. And then the volunteers take them up to the floor where they had their transplant and they give out these lifesavers, thanks for saving my life. So we work on the bedside nursing, but I think we try to constantly have our hands in bedside nursing so they affiliate themselves with us. They're part of this program.
Yeah, a lot of sense. Any other questions? Steve?
Excellent presentation. I have a question. How do you disseminate standards of practice to your transplant coordinators? Do you do it randomly, or is there a thought out? Do you have it put away somewhere, or how does that?
Well, I mentioned we have that in Transplant U, everybody who onboards has set aside time to review that when they're onboarding. Annually, we have a skills fair, and then we know that's a concentrated time. They're going to be refreshed on all of it. And if we have administrative or protocol updates in the middle of the year, we use those screener videos as a digestible way to learn things. When we were just passing out policies, we felt they were sort of being read with no emotion and not learned. But now that we do the screener videos, I call them, they're much shorter, but they're the TED Talks of transplant. Like, why did we do this? What did we do? Where can you reference it? And, and if something came up like Dr. Half really wanted to make sure I stressed to you in this policy, anything that just mixed it up a little bit, it wasn't just hearing something over and over. So that's how we do it.
Any other questions? Well, thank you very much.
You're welcome.
Terrific.